Hi everyone, today we're going to talk about recognition and acute management of increased intracranial pressure. You may be thinking, I'm not an ICU doctor, why does this matter to me? Well, let's say you're working in the emergency department and you have a patient with a gunshot wound to the head come in. Or you're on the floor taking care of a patient with diabetic ketoacidosis who now has developed cerebral edema. Or you're on the AFLAC unit and your patient with a posterior fossa tumor develops obstructive hydrocephalus. I would argue that each of you could encounter a patient with increased intracranial pressure regardless of your subspecialty. My goal for today would be that you be able to recognize it and take the first steps in managing it. Now let's talk about why do kids get increased intracranial pressure? The reason behind this is explained by something called the Monroe-Kelly hypothesis. The Monroe-Kelly hypothesis states that the skull is incompressible and the volume inside of it is fixed. That volume is made up by three parts: the brain tissue, which represents about 80% of the volume, blood, which represents about another 10% of volume, and CSF, which represents the last 10%. All three of these components exist in equilibrium, and if any one component increases, another component must decrease in order to compensate for that change. For example, if you develop a head bleed, or let's say an epidural hematoma, the blood compartment has now increased in size, and so another compartment needs to compensate. So one way to compensate would be to divert CSF down the spinal column and give more room for the blood to expand. However, these compensatory mechanisms can only regulate your intracranial pressure so far. And as one compartment continues to increase, initially you won't see any change in that intracranial pressure. But when you overcome the compensatory mechanisms and your volume inside the fixed space continues to increase, you develop an increase in intracranial pressure. Now let's talk about what are the signs and symptoms of increased intracranial pressure. First, let's talk about Cushing's triad. So as your intracranial pressure increases, your body tries to maintain cerebral perfusion pressure. So I'm sure we all remember cerebral perfusion pressure, or CPP, is equal to your mean arterial pressure minus your intracranial pressure. So it would make sense that as your ICP increases, in order to maintain your cerebral perfusion pressure, you need to drive up your mean arterial pressure. So that's why these patients become hypertensive. In response to the hypertension, your body has pressure receptors, or baroreceptors, in the carotid sinus that sense that high blood pressure and then reflexively drop your heart rate. So that's why you get the combination of hypertension and bradycardia. And then the last component of the triad, as the brain continues to swell and the brainstem becomes compressed, that's where you get your disordered breathing, where you can be bradypneic, apneic, or have Cheyne-Stokes-like respirations. Another sign of increased intracranial pressure is bipupillary changes. So you can have anisocoria, where one pupil is larger than the other and either sluggish or unreactive. Or both pupils can be affected. The last symptom I want to talk about is posturing. So decorticate posturing is where the arms are up in flexion toward the chest, toward the heart, and decerebrate posturing, which is more ominous and in sign of impending herniation, is where the arms are down and extended away from the body. And now that you know 3 symptoms of increased intracranial pressure, the most important thing you can do when you recognize these in your patients is don't panic. So let's talk about 3 easy management steps you can take to lower intracranial pressure while help's on the way. Step 1 would be to elevate the head of the bed. We usually think of at least to 30 degrees. This is going to promote drainage of blood and CSF down into the spinal column and away from the intracranial compartment. Step 2 would be to hyperventilate the patient. The relationship between cerebral blood flow and CO2 levels is fairly proportional. So that as your CO2 levels are higher, your cerebral blood flow increases, and as your CO2 levels are lower, your cerebral blood flow decreases. Therefore, it makes sense that hyperventilating your patient and decreasing their CO2 levels is a fairly effective way at reducing cerebral blood volume and therefore decreasing intracranial pressure. The last step would be to give something like hypertonic saline, or an agent that increases the osmolality of the blood. So as the osmolality of the blood increases, water will be drawn away from the brain parenchyma and into the intravascular space, where it can then be diverted away from the intracranial compartment, and thereby decrease intracranial pressure. All right, so now we've gone over signs of increased intracranial pressure and 3 easy steps you can take to treat it while help is on the way. Let's review. So the first sign we talked about was Cushing's triad, which consists of high blood pressure, low heart rate, and then depressed respiratory effort or apnea. The next sign was pupillary changes, such as anisocoria or bilateral fixed and dilated pupils. And then lastly, posturing, either decerebrate or decorticate. Then we said there were 3 things you could do to decrease intracranial pressure while help was on the way. The first was to elevate the head of the bed to at least 30 degrees. Then to hyperventilate the patient to drive down their CO2. And lastly, administer a hyperosmolar agent like hypertonic saline to draw water into the intravascular space. Now you should be able to both recognize and take initial steps in the management of increased intracranial pressure.